Hello everyone, today we will share our views and solutions for Black maternal health disparities. The purpose of us choosing this topic is because Black women in the United States experience unacceptably poor maternal health outcomes, including disproportionately high rates of death related to pregnancy or childbirth. Both societal and health system factors contribute to high rates of poor health outcomes and maternal mortality for Black women, who are more likely to experience barriers to obtaining quality care and often face racial discrimination throughout their lives. The problem here is that in the United States, Black women and white women experience fertility at the same rate. Unfortunately, maternal outcomes for Black women are more than twice as severe than for white counterparts. In the U.S. alone, Black women are approximately twice as likely to have a preterm birth and are 3 to 4 times as likely to have a very early preterm birth than women from other racial or ethnic groups. The adverse maternal disparity that exists between Black and white women seems to be the result of policy that fails to use cultural competency to address the needs of Black women's health. Now, current policies adhere to a standardized provision of health services that do not implicitly address the social determinants of health, especially for Black women. Today, we will be talking about 3 proposed solutions to help this issue. The first issue will be using incentives to motivate women to seek prenatal care. Our second solution would be restricting Medicaid from sending mothers to hospitals with adverse maternal outcomes after these outcomes are adjusted for. Finally, our third solution will be expanding Medicaid coverage to include doulas for all African American women to reduce low birth rate. Hello everyone, my name is Tatiana, and I will be guiding you through the first solution, which is using incentives to motivate women to seek prenatal care. Now, the effectiveness of this proposed solution is that with the example of in the state of Alabama, they have an initiative by the Alabama Medicaid Agency that developed Healthy Beginnings, which is an awareness program which utilizes coupons to motivate women to seek prenatal care. Now, preliminary data analysis reveals that this incentive program may be a significant factor in motivating women to seek early and continuous prenatal care. The importance of this was that in 1990, 26% of all women delayed entry to care until their 4th month of pregnancy. Additionally, more than 1,000 women in the state received no care at all. In many of these cases, women perceived prenatal care as unimportant or unnecessary until later in pregnancy. As a result, Alabama developed Healthy Beginnings to help women seek this prenatal care that is ultimately very important. Now, pregnant women can receive the coupon book, which is worth about $300, simply by dialing a toll-free number. To take advantage of the free gifts and discounts, expectant mothers must visit a private physician or health clinic and have their coupons validated monthly. Now, this project was initiated in August of 1990 and has already had clear evidence that the use of these incentives represents a viable outreach strategy to motivate poor and uninsured women to seek this prenatal care. In the program's first year, more than 20,000 women received the coupons, of which 78% were Medicaid recipients, uninsured, or in presumptive Medicaid eligibility period. Looking into the equity for my proposed solution, this will be horizontally equitable because it will increase transparency in programs that are already in place to help prenatal care occur. Now, this is vertically equitable because this will develop opportunities for patients with financial burdens, Therefore, financial incentives will attract those who need the financial ease to seek prenatal care. We go into the stakeholder support and opportunist potential for my proposed solution. Now, 3 organizations that stood out the most were March for Dimes, the Alliance for Innovation on Maternal Health, and California's Maternal Quality Care Collaborative. Now, March of Dimes has a mission of enhanced prenatal care. This means that they ensure that women have access to prenatal care and services throughout their pregnancy, and knowing that it is a vital role that it plays in communities. Now, March of Dimes also has the opportunity of bringing high-quality, evidence-based interventions and healthcare to underserved areas, or striving to increase services for pregnant women to help them adopt healthy behaviors. March of Dimes staff and volunteers strategically focus on resources and funding in the areas with the most need and potential for impact. AIM is a national alliance to promote consistent and safe maternity care to reduce maternal mortality by 1,000 and severe maternal morbidity by 100,000 instances over the course of 4 years. It is funded through the Federal Maternal and Child Health Bureau. Lastly, we have the California Maternal Quality Care Collaborative. The California Maternal Quality Care Collaborative is a multi-stakeholder organization committed to ending preventable morbidity, mortality, and racial disparities in California's maternity care. CMQCC uses research quality improvement toolkits, statewide outreach collaboratives, and its innovative maternal data center to improve health outcomes for mothers and infants. CMQCC was founded in 2006 at Stanford University School of Medicine together with the state of California in response to rising maternal mortality and morbidity rates. Since then, California has seen maternal mortality decline by 55% between 2006 through 2013, which is what you see on this graph here. Lastly, we go into political feasibility for my proposed solution. Lawmakers are prone to support this initiative because of the statistics with maternal mortality and the way it is dramatically increasing. On December 21st, 2018, the Preventing Maternal Deaths Act was signed into law. This legislation sets up a federal infrastructure and allocates resources to collect and analyze data on every maternal death in every state in the nation. The bill is intended to establish and support existing maternal mortality review committees in states and tribal nations across the country through federal funding and reporting of standardized data. Now, laws like these will reach opposition because of funding. Funding opportunities to support implementation of the act must align with the intent of the legislation.
My name is Rebecca Etienne, and I'm going to go into our second proposed solution, which is to restrict Medicaid from sending mothers to hospitals that are demonstrated to produce adverse maternal outcomes, namely disproportionately high maternal and neonatal mortality. So first off, it's important to note that hospital performance with respect to adverse maternal outcomes needs to be determined objectively. For instance, Hospital A can appear to be worse performing than Hospital B if it has a higher proportion of adverse maternal outcomes produced per unit time than Hospital B does. But a basic proportion would not capture the truth of hospital performance because it fails to consider other factors affecting maternal outcomes that may be at play in the region where the hospital operates. For instance, the average age of mothers in that region, or the prevalence of behaviors such as previous or current tobacco use or exposure, all of which are known to adversely impact pregnancy outcomes. And so in order to objectively assess hospital performance, you would have to produce, for example, an age-adjusted, behavior-adjusted rate of adverse maternal outcomes for each hospital, and then compare those adjusted rates to each other to determine which hospitals are truly, objectively operating subpar. Now, once that objective, or at least more objective list is established, then the implementation of this solution would continue forward, with insurers reducing their list of approved hospitals that are able to accept Medicaid for the delivery of antenatal and neonatal care. The providers that remain after the list is reduced would have historically demonstrated satisfactory maternal health outcomes pursuant to whatever requirements were delineated in the federal or state legislation that required this reductive action to occur in the first place. So, in order to fully assess the viability of this solution, we have to look at its effectiveness, its equity, its stakeholder support, and its political feasibility. So in terms of effectiveness, excluding hospitals from insurance program networks has been previously done across the nation to minimize costs since the advent of the ACA, or Affordable Care Act. Specifically, this occurred in Massachusetts in the months following ACA implementation, where insurance plans excluded some of the highest charging hospitals to manage their costs. Since the exclusion of hospitals from insurance program networks has been previously effective at reducing costs on specialist and hospital care, it is reasonable to project that the same concept can be used to increase quality of care in hospitals. So in terms of effectiveness, we rate this solution as a 4 out of 5, as it has historical evidence of its potential viability. Now, in terms of equity, we looked at this solution through both a horizontal equity and vertical equity lens. So horizontally, this solution is equitable. The newly pruned list of hospitals would still be Medicaid hospitals. Medicaid coverage is intended to serve elderly people, low-income people, some families and children, people with disabilities, and most pertinently to this issue, pregnant women. Inevitably, there will be individuals covered under Medicaid who are at the intersection of being both low income and pregnant. And since both of those groups are covered here, this solution may address the plight of economically disadvantaged mothers with additional specificity. So this solution is horizontally equitable. In terms of vertical equity, care provided at hospitals that routinely produce more favorable health outcomes will inevitably cost insurers more than care provided at hospitals with worse outcomes. This will cause additional costs to the insurers by decreasing their profit margin rather than by increasing the expense to the buyer. So this solution is vertically equitable. And so in terms of equity, we rate this solution as a 5 out of 5, as it addresses horizontal and vertical equity concerns well. Moving on to stakeholder support and opportunist potential. There are several interest groups that advocate for improved maternal health outcomes in the United States. Planned Parenthood, the U.S. Department of Health and Human Services Office of Women's Health, and the Black Women's Health Imperative are among the heavyweight stakeholders for this solution. At the grassroots level, organizations such as the Maternal Health Task Force and Back Her are additional stakeholders. These stakeholders would be able to lobby insurance companies to only cover antenatal and neonatal care at hospitals with satisfactory maternal outcomes. They would also be able to lobby Congress people for the advancement of the same cause. Now, in terms of stakeholder support, we rate this solution as a 4 out of 5 since there are numerous highly influential interest groups in support of improving the quality of antenatal and neonatal care across the nation and, by default, improving maternal health outcomes across the nation. So in terms of political feasibility, this solution is politically feasible by virtue of its previous use and effectiveness. In the past, federal programs restricted hospital selection in order to control costs. So it's reasonable to deduce that quality control concerns can be addressed in a similar manner. There is congressional democratic support for the improvement of maternal outcomes. Robin Kelly, a Democrat from Illinois, introduced the Mamas Act to address maternal mortality in 2019. Congressman Joe Kennedy III, a Democrat out of Massachusetts, has also publicly supported this issue, as well as Governor Eric Holcomb, who is the Republican governor of Indiana, who signed a bill creating a maternal mortality review committee to scrutinize deaths and near deaths among expectant and new mothers and make policy recommendations to improve maternal health. The strong support for maternal health reform on both sides of the aisle suggests that this solution may be politically feasible. Maternal health reform is not a contentious issue, with Democrats and Republicans alike agreeing that action needs to be taken to improve maternal outcomes. This particular solution, however, to prune the list of Medicaid hospitals providing antenatal care and neonatal care, will likely be met with some opposition. Due to the two-tiered characteristic of the United States health system, hospitals that demonstrate better health outcomes often charge more for their services. Since the newly restricted hospital list will be a derivative of the old one, it will include hospitals that are already covered by Medicaid. Thus, out-of-pocket costs to the consumer may not increase. However, costs to the insurer will be higher than in previous years, since all maternal care would be delivered at higher quality hospitals, necessitating greater costs to the insurer and potentially to the federal government also, by way of higher reimbursements. It is therefore feasible that some insurance companies and some Congress people will be opposed to this solution on the premise of spending. Despite this anticipated opposition, however, we maintain that the benefits of this solution outweigh the costs. So in terms of political feasibility, we rate this solution as a 3 out of 5. Because although there is significant bipartisan support for the general improvement of maternal outcomes, opposition for congressional initiatives on the basis of spending concerns or concerns of balancing the budget has served as a strong counterargument in the past, slowing and at times even halting the progress of otherwise widely beneficial legislation. And so, as with any other policy issue, the policy window for this solution would have to be open for it to succeed. And so overall, this solution to restrict Medicaid from sending mothers to hospitals that produce objectively adverse maternal outcomes is rated as a 16 out of 20.
Hello everyone, so my name is Erica Stewart and I'll be presenting Solution 3 in our goal year matrix, which is to expand Medicaid coverage to include free doula services for all African American women in an effort to reduce low birth weight. This is in our goal year matrix. This solution was rated on a total out of 20. It was given a 15. And the rationale for choosing this solution was that the literature around African American maternal outcomes showed that the leading cause of infant mortality amongst African American women was low birth weight. So it was my idea that if we are able to reduce low birth weight, we might be able to in turn reduce the adverse maternal outcomes for African American women. So does that work? Does providing doula services work? Has it been done before? And so the answer is yes. As we see here, the NYC Department of Health implemented the By My Side program. And the By My Side program, what it did was it offered free doula services for African American women who have been traditionally underserved and marginalized. So specifically Black and Latino women. The services included, but was not limited to, prenatal care, education, discussion, advice, and then during pregnancy, the doula is present, and then afterward, this doula follows up with these women at least 3 to 4 times afterward, just to make sure that they're okay, and to give them guidance and anything else that they may need at that time. And so what's interesting about the By My Side program was that 6.5% of the Black women enrolled in the program experienced low birth weight, whereas 12.4% of the Black women in the same research area experienced low birth weight. But these women were not enrolled in the program. So effectively, the By My Side program was able to reduce low birth weight for about almost half. So by about almost half. And so, I thought that. And then another research study done in Minnesota showed that women who had received doula services throughout their pregnancy were less likely to Black women who received Medicaid were less likely to experience low birth weight when they had seen a doula. So that was essentially, doulas are effective, and I think that is proven there in those studies. So let's move on to equity. And so in this solution was assessed for horizontal equity as well as vertical equity. And so horizontally, we compared all Black women. So Black women of low, medium, and high income are addressed in this solution because all Black women would be given free doula services. Because across socioeconomic profiles, Black women experience low birth weight and infant mortality at relatively the same rate. Vertically, this solution compared Black women to white women, and all other women of all other ethnicities, to be honest. And still, there is not as a severe or immediate need to reduce adverse maternal outcomes, except for in Black women. The figure below shows shows low birth weight data for the U.S. from about 2006 to 2015. All other ethnic groups in this model have relatively moderate to medium and low birth weight percentages, whereas Black women have almost twice that of all other ethnic groups. And then not only do they have twice the number, but it hasn't changed over the past 13 to 14 years, according to this graphic. Like it hasn't changed. And those rates are fairly consistent even with as of late of 2018. So essentially this solution is vertically equitable because there is no other ethnic group with the same needs. And then it is horizontally equitable because it identifies people who are the same, Black women across socioeconomic profiles, as having similar needs. And so, yes, so the solution addresses both vertical and horizontal equity. Moving on to our stakeholders. Now, the stakeholders that were chosen for this particular solution were the National Planning and Reproductive Health Association, the National Partnership for Women and Families, and the National Organization for Women. Another organization that was chosen was the Office of Health Prevention. Is it health prevention? I think that it's the Office of Disease Prevention and Health Promotion, and essentially, I think that of these of these stakeholders, the Office of Disease Prevention and Health Promotion would probably be the strongest ally when it comes to lobbying, because they have a very strict initiative and they were established by Congress. Congress established this organization to promote health and promote healthy behavior and better health outcomes for Americans. And so I think that they would have the biggest pull when it comes to lobbying. However, the National Partnership for Women and Families has a lot more influence in the maternal community. They have the research, they have the background, they have the framing, they have the context. And I think that among all four of these organizations, I think that all of these organizations can really contribute if they create an allied partnership. They can change the way that Black women experience maternal health outcomes by way of lobbying and by way of having new policies implemented. The National Organization for Women specifically, they have a very strict, not strict, but they have a very to the point directive and mission statement. They are established to better women's health, whether it's maternal, whether it's quality of life, whether it's obesity, whether it's any of these things. And I feel like they might be the ones who are able to give women in this particular issues the light that it needs to shine in order for this to become in order for this to be understood in the broader arena. And so moving on to political feasibility. So in a Lancet article that I was reading, he talked about two of the major influences of political feasibility is the strength of the actors involved and the power and ideas they use to portray the issue. Now, portraying the issue, I think, is going to be the biggest contributing factor of getting this particular solution to become policy. So, because I think that if this issue is framed in the context of humanitarianism and the welfare system and disparity and reparation in many regards, I think that it will be shot down and forgotten and not accepted like many other humanitarian and welfare issues. However, I think if this issue is framed as an investment into healthcare, an investment into the economy, an investment into the youth, an investment into essentially our future, the viability of our future, I think that only then will it be accepted, harnessed, and agreed upon, and in many ways, made better. So I think that as far as if this, again, I say that this solution was ranked at 15 out of 20, but I think that if this issue can be framed properly, then it could definitely become policy. And that is all for this presentation. And now we will allow for questions.